Welcome. In this explainer, we're diving into the critical next steps for managing persistent postural perceptual dizziness, or PPPD. We'll look at the common pitfalls in treatment, find the best way to talk to patients, and get really clear on when it's time to refer. Just so you know, everything we're covering here is based on the Persistent Postural Perceptual Dizziness Clinicians Literature Review, which was published by the Australian Dizziness Clinics. So get this is what's so important. We've got a treatment that really works for 60 to 80% of patients, and yet a lot of them just aren't getting better in primary care. The key here, the reasons they fail are almost always predictable, which means they're also preventable. And that's exactly what we're going to tackle today. We'll break down the 6 most common pitfalls that can totally derail treatment. I'll share a communication script that actually gets patients on board, and we'll clarify the exact criteria for referral. Okay, let's start with what not to do. Honestly, these 6 pitfalls are the most common reasons a patient with PPPD just doesn't improve. If you can avoid these, it's probably the single biggest thing you can do to change their outcome. So let's jump in with the first pitfall. This one really gets to the heart of a major misconception about this condition. This is a huge one. Yeah, anxiety is often there. It's a common comorbidity. But PPPD is its own thing. It's a sensory motor disorder. Simply telling a patient their dizziness is just anxiety isn't just wrong. It completely shuts the door to the specific 3-pillar treatment they actually need, like vestibular rehab. The second common mistake involves medication, but maybe not in the way you'd think. This is just actively working against what we're trying to do. Things like prochlorperazine or benzodiazepines might seem like a quick fix, but they actually stop the brain from recalibrating. They blunt that central adaptation process that we're trying to kickstart. A lot of the time, the best first step is to start deprescribing these. Our third pitfall, this has to do with the advice we often give patients about their day-to-day lives. You know, it seems so logical, right? Tell a dizzy patient to avoid busy supermarkets or quick head movements. But with PPPD, that just feeds the problem. The whole point of vestibular rehab is graded therapeutic exposure to those exact triggers. It's about teaching the brain that those things are actually safe. Avoidance just keeps the brain stuck on high alert. All right, moving on to number 4. This one is absolutely crucial for medication adherence. This is a critical counseling point. You have to tell your patients that SSRIs and SNRIs often make their dizziness feel a bit worse for the first week or 2. It's an expected side effect. If you don't warn them, they'll think the medication is hurting them, they'll stop taking it, and they'll never get to that 6 to 12-week mark where the real benefits start to show up. The 5th mistake is all about looking beyond the PPPD diagnosis itself. So remember, PPPD rarely exists in a vacuum. It often overlays other conditions. If your patient also has active BPPV or vestibular migraine, you have to manage those at the same time. If you only treat the PPPD and ignore the other active issues, your treatment is likely going to fail. And our 6th and final pitfall. This one deals with a common delay in getting effective treatment started. Let's be really clear here. PPPD is a positive clinical diagnosis. You make it using the Barani criteria. It is not a diagnosis of exclusion. Once these criteria are met and there are no red flags, the right move is to start treatment. Delaying rehab for months while you wait for another MRI just to be sure is actually harmful and lets those bad habits get even more wired in. So we've gone through what not to do. Now let's talk about maybe the single most powerful tool for getting this right, your communication. Seriously, how you frame this diagnosis can make or break the whole plan. This analogy is absolute gold. You say something like this. Look, your inner ears and your brain are structurally fine, but after that event that kicked all this off, and that event was real, your balance system is now stuck in high alert mode. It's like a car alarm that just won't stop going off. So we have a 3-part plan to basically reteach the system how to switch off. This works because it validates their experience, frames it as a fixable software problem, not a permanent hardware one, and gives them a clear, hopeful path. It's spot on, it's not dismissive, and it really empowers the patient. Now, while you can manage most patients in primary care, some are going to need specialist input. The key is knowing who and when. This isn't about referring everyone, it's about referring smartly. Okay, so you refer for specific reasons. Refer if you're just not sure about the diagnosis, especially if there are red flags like oscillopsia. Refer if the patient isn't getting better after 3 to 6 months of good combined therapy, if they have complex comorbidities, or if they just can't tolerate the first-line meds.
And of course, if the patient asks for an expert opinion, you refer. But just remember, a confident diagnosis and early treatment from you often works better than a referral-and-wait game.
Phew, we've covered a lot of ground. So let's just boil this all down to the key things that can really change your practice. First, success with PPPD is mostly about steering clear of those 6 predictable pitfalls. You do that, and most of your patients are going to improve. Second, use that car alarm analogy. It is the key that unlocks patient understanding and gets them to commit to the plan. And third, know your referral criteria. Refer smart, not automatically, to get the right patients the specialist care they need right when they need it. And that brings us to the end of our 3-part explainer on PPPD. We started with how to recognize it, then we moved to the 3-pillar treatment, and now we've covered the pitfalls and referrals. You should have a really solid toolkit now for managing this very common condition. For more deep dives into dizziness and to get your hands on resources for both clinicians and patients, just head over to AustralianDizzinessClinics.com. If you found this useful, please do subscribe and share it with your colleagues. Thanks so much for joining us.